Okay. Hello. So everybody's here or everybody left? Okay, fine. So let me introduce the last session of the very last two talks. I'm really honest to welcome here Shiv. Shiv is Karan Shiv is my friend, my personal friend. We are actually presenting and working long time together. He is one of the main experts for sympathetic and parasympathetic autonomic regulations. Actually, and who else and who better could be able to talk about the topic. So actually, the thoracic sympathectomy in the management of electrical storming is the best topic for him to conclude this nice Prague rhythm. Oh, I will conclude, but no, it's your final talk, okay? Thanks, okay.
Thank you so much for that kind introduction, Peter. And again, Professor Kotzner, it's a great honor to be back here in Prague. Can I see my first slide, please? Thank you so much. So this is our home, California. So come to UCLA if you're in California. So any of our presentations, we usually have to thank all our colleagues. So the work you're going to be seeing over here, we're going to be talking to you something about futuristic. So hopefully in Prague 2025, we'll do some live cases for you about the new technologies that are coming out in this space. So as you know, neural control of the heart is not just for arrhythmias. It's actually having a big impact for all these conditions, all these diseases. But it turns out that this is going to have a very big impact in not just ventricular arrhythmias, but also sick sinus syndrome. You heard this entire session on cardioneural ablation. It's also making a comeback for angina. So, and I'll tell you why. So let's spend a minute or two about pathophysiology to give you an update of what has happened in the past decade. So if you open up any textbook, the first thing you'll see is there are two limbs of the nervous system, the sympathetic and the parasympathetic system. What you see over here is the sympathetic system actually is thoracolumbar, right? So if you look at this, the thoracic cord is, has a little bit of an extension over here. This area and the lumbar, so it's thoracolumbar. The preganglionic fibers go to these paravertebral ganglia. From there, they synapse and go to various organs. The parasympathetic system is craniosacral. So that is the vagus and also the other cranial nerves for the, the eyes and other organs. And then you actually have the lumbosacral system. So again, what is the big difference? Here, the preganglionic fibers come all the way from the nervous system and they synapse very close to the heart, which is why in cardioneural ablation, the session that you saw before, most of the ablation targets are actually within the you target close to the organ, like the fat pads of the heart. Now let's try to actually look at this a little more closely. I'm not going to spend a lot of time going over this circuit diagram for you. But just suffice to tell you that at the level of the heart, where you see the fat pads, they sit on the surface of the heart. That is called the intrinsic nervous system of the heart. Then you have the extrinsic nervous system of the heart. This is the nerve plexus, and I'm going to show you some very beautiful images of that. So see, these are the nerve fibers coming to the heart. And finally, you have the highest centers. All these structures together, they form what is called, a sort of what are called nested loops. So signals going from the heart are going to the intrinsic nervous system of the heart. So they're called cardiac reflexes. And some of you may not know this, and people are very surprised when I tell them. The only reason a transplanted heart works is because the fat pads are intact. Does that make sense? So think of the heart like an engine that has its own computer chip. That's what you're trying to sort of focally ablate when you're doing cardioneural ablation. And I think those neurons are hyperactive, which is why for POTS and for heart block, you can actually ablate those neurons and modulate the heart. Another set of signals go from the heart to the stellate ganglia back to the heart. Those are intrathoracic reflexes. Then you have signals going from the heart to the brainstem, heart to the spinal cord, and they come back to the heart. So the efferent fibers, what are called also cardiomotor fibers, are sympathetic and parasympathetic, and we generally remember this as sympathetic accelerates the heart, parasympathetic slows down the heart. They do a lot more. They release not just neurotransmitters, but they also release neuropeptides. And that becomes very important because all the physiologic functions of the heart are under neural control. Every single function of the heart is under neural control, including post-injury scar formation. That is how important it is. Now, if, say, this minute there's a fire alarm that goes off, every one of us, our heart rate will start going up. That is sympathoexcitation. Why do we have that? Because you need to run and save your life. That reflex goes from the brain. It's an alarm signal for the entire human body. Okay? That's what, when you read in textbooks, people call it fight or flight response. But we forget that the exact same reflex can be initiated from the heart itself. Isn't that amazing? That is like you going and having a light switch that is a two-way switch, right? You can activate this alarm from two sides. So the signal going from the heart to the brain is as powerful as you hearing a fire alarm. So that is the level of sympathoexcitation that occurs if you have heart disease. So the entire field of heart failure, when you see patients who are being treated with beta blockers, ACE inhibitors, all the drugs we use to treat heart failure, it is treating this reflex, signal going from the heart to the brain. Does that make sense? So therefore, that is how fundamental neuroscience is. So our hope is, now this is actually a confocal image over here. We've actually stained for smooth muscle actin, and what you see over here in blue are nerve fibers. There's not a single cell in the heart that is not connected to the nervous system. And it turns out, if you go on rounds, all that you see in clinical practice, post-infarction, post-myocarditis, altered mechanics, if you do RV apical pacing, PVCs, drugs, diet, depression, all of these activate the neuroendocrine system, which is why you get heart failure. Now, we even know stress can cause heart attacks, right? Atherosclerosis. Let's see what happens once you get an injury to the heart. The heart starts sending signals to the brain as if the alarm is on. So the brain now has the activation of the renin-angiotensin system, the neuroendocrine system, which is why you end up having to treat with beta blockers and ACE inhibitors. And in fact, the entire success of our field of cardiology is because we are treating all the downstream effects of this signal going from the heart to the brain. And that's what causes remodeling and heart failure. So the big hope for us as interventionalists, of course, is to see if we understand the anatomy of these structures better, and we can actually deliver either drugs, biologicals, or even bioelectronics to various sites. So what happens when you have an injury in the heart? There is remodeling. Nerve sprouts occur at the location of scars. There is also inflammation of the stellate ganglia, plus remodeling of the higher centers. Together, these things cause arrhythmias and heart failure, the biggest problems in cardiology. And it turns out with time, as disease progresses, things get worse and worse. And in fact, very recently we published a study. This is my colleague, Dr. Ajijola, and their team. This is a collaborative study with Harvard, which actually shows if you measure neuropeptide Y, which is a sympathetic neurotransmitter, it's a blood test, you can actually see how dramatic the outcome is. Look at this. If your NPY level is greater than 130 picograms per ml, you're dead in 3 years. It's worse than some cancers. Do you see the power of the nervous system? So this is why, sort of the importance of this concept and modulating it becomes very, very important. So how do we go about modulating it? There are two ways you can modulate it. One is you can cut down sympathetic drive, or you can increase parasympathetic drive. And why are we discussing this at Prague? There are many, many, many interventions that are coming up. All of this is based on techniques. And you know this, like 3 years ago in Prague, there was a live case of RF ablation of the stellates. So you're going to see more technologies that are going to come up in the future sessions, and we are hoping that maybe in Prague 2025, we'll be able to show you some new technologies. So how do these things work? In general, the purpose of all neuromodulation is to decrease sympathetic drive and increase the parasympathetic drive. You can increase parasympathetic drive by VNS, tragus nerve stimulation, and you can also do things like spinal cord stimulation. So there's an entire ecosystem of neuromodulatory therapies that are coming up. Why do we focus on the sympathetic nervous system? Because when you look at what happens to myocardial electrical propagation, these are scars, this is reconstruction in both experimental infarcts, and now we've also done these studies in humans. So when you stimulate the sympathetic nerves, there are dramatic changes in electrical propagation which are pro-rhythmic. Therefore, if you can cut down sympathetic drive, it helps patients. Now let's take some clinical cases. Here's a patient who presents, 49-year-old female, non-ischemic cardiomyopathy, EF of 30, VT storm, has had previous failed ablations, incessant VT. What do? Patient is intubated. Such a patient, we admit them in the ICU, and typically the way we treat them is we give them beta blockers, we sedate them, and we can institute thoracic epidural, or you can do stellate ganglion blockade. How do you do stellate ganglion blockade? You can do it at the bedside, ultrasound guided. If you inject lidocaine, you can also use bupivacaine, a longer acting version of lidocaine. That actually controls VT storm. And study after study has shown that this is absolutely needed. You should, if you're a VT center, you have to have a pain management anesthesiologist as a part of your team. Now, anytime when a patient is stable, and in fact, this is what the bulk of my personal clinical practice and what we do at UCLA and how we got into sympathetic modulation was because of catheter ablation of VT. As you saw so many cases at this meeting. So catheter ablation of VT has had a huge impact. It's probably of all the ablation procedures we do, it is a life-saving procedure. Now, in a scar border zone, again, these are confocal images, both in human infarcts and in animal infarcts. What you see is experimental infarcts, that the border zones of scars actually have a lot of nerve sprouts. So one of the mechanisms by which catheter ablation itself works is because of neuromodulation. So that's an important point to keep in mind. Now, moving further, let's now spend a little bit of time looking at the anatomy. This is for those of you who have a minute, you can capture this QR code. You can download the first volume of the anatomy book that we made available open access for the world. Volume 2 of this book that Rod Tung and myself have published along with Shumpei Mori is going to be released next month at the HRS. And what you see over here is a cadaveric dissection showing you all the nerves of the heart. And you can see this is the spinal cord, these are the dorsal roots, and shown in yellow are all the nerves, phrenic, vagus, sympathetic, and parasympathetic nerves. I'll play this once more so that you can actually briefly see this. You can see this. This is, you can see these are the phrenic nerves that are long ways. And then you can see the vagus. And over here you can see all the plexi, right? So this is the deep and the superficial and the deep cardiac plexus. And these nerve fibers play a very, very complex targets. And right over here, you see these are the stellate ganglia, right over there. Do you see that? That is the right stellate, because it looks like a star. You see that? I'm going to pause it here. And let's now look at the stellate. 100 years ago, there was no coronary angiography. And the only way in which angina was treated was by this surgeon from Romania, UNESCO, practicing in Paris. He actually surgically cut the stellate ganglion, and that's how it came into clinical practice. Subsequently, in the mid part of last century, most patients with angina, and there have been large series that were published, for surgical relief of angina pectoris. Now, it turns out it is an excellent way of reducing sympathetic output to the heart. Many investigators, including us, for structural heart disease, and Gaetano Di Ferrari and Schwartz and these people, and especially Dr. Art Moss and Doug Zipes, first showed that this could be used for treating long QT syndrome. Therefore, since 1960s, we've known that sympathectomy can work. It's only in literally 15 years ago that we started using it for patients with BTBF storm. And what have we found? We and other groups, and I believe a couple of people over the break were asking me about this. The way the procedure is done is video-assisted thoracic surgery. Under direct vision, we cut half the stellate all the way down to T4. Intraprocedurally, we prove with frozen sections that the sympathetic nerve fibers have been removed. And this has an extremely good outcome. And we now have, at least in CPVT and long QT, we now have follow-up of patients who've had it almost for 30 to 40 years. And this is an international collaborative study. We actually showed that bilateral cardiac sympathectomy is better than unilateral, especially in structural heart disease. Therefore, it's a life-saving procedure. To the extent, we now at UCLA, we actually have an interventional neurocardiology program where we have thoracic surgeons, anesthesiologists, and also neurosurgeons as a part of the same team. So I'll leave you with one interesting thought over here, and that is, how does this procedure work? In the last minute or two, let me tell you this. So the way sympathectomy works, and this is a very important concept, it works by preventing the amplification of sympathoexcitation. The signals going from the heart to the brain, it's not the efferent, it is the afferent limb that is a big modulator. So here's an experiment where we do coronary occlusion, and there are sort of 3 regions from which we are measuring actual myocardial concentration of norepinephrine. So the protocol is to occlude the coronary artery and then recover it. And over here, you can see what happens. Baseline, when you occlude the coronary artery, you can see that the norepinephrine level goes up, and then during reperfusion, it comes down. Now, if you look at what happens in the ischemic zone, which is here, and this is the normal zone, remote zone. So if you look at animals, some animals fibrillate, and some don't. So the animals that fibrillate have a much, much higher level of norepinephrine release. Do you see that? High release of norepinephrine, there's fibrillation. And look at what happens if we now do an experiment which mimics what we do clinically, which is cardiac sympathectomy, or even some extreme example, which is autotransplant of the heart. So if you cut these nerve fibers going from the heart to the brain, let's see what happens in the first scenario, which is, let's take baseline. Nothing has been touched. So if you occlude a coronary artery, there's a 152% increase in norepinephrine. And what happens is 38%. Over a third of animals fibrillate. Now, if you mimic, cardiac stellate ganglionectomy, right? Sympathetic denervation, there is still a 114% increase in norepinephrine. However, look at what happens to incidence of EF. It comes down from 38% to just 8%. And of course, if you do all the way down, if you cut every single nerve fiber going to the heart, there's only a 16% increase in norepinephrine, and again, you've reached a plateau where you've been able to reduce the risk of fibrillation. Now, it turns out that spinal cord stimulation, I didn't show you in this slide, and the paper has the detailed data, has a similar effect. So the concept to keep in mind is, if you can cut the signals going from the heart to the brain, you can dramatically reduce the incidence of fibrillation because you're cutting down the release of norepinephrine in the heart. So what is the future? So hopefully in Prague 2025 and beyond, you're going to be seeing new technologies. Instead of sympathectomy, we're going to be having special bioelectronics where we implant leads and we target the T1, T2 section of the sympathetic nervous system. And we already know that if you use a special kind of electrical stimulation, so the future devices are going to be what is called closed-loop neuromodulation. So you're going to actually have devices that can sense arrhythmias, sense biomarkers, and it'll target these regions with electrical wires, bioelectronics. And this, of course, you can see that it dramatically reduces the risk of arrhythmias. Therefore, the future of these kinds of devices is to prevent arrhythmia from happening in the first place by monitoring. This is where AI, ML, monitoring rhythms becomes much more important. So our hope is that it's going to be a completely percutaneous procedure. Instead of calling a thoracic surgeon, it'll be done by us. And I'll finally leave you with one last thought. Many of you may know that JACC, the family of journals, now they've merged so that JACC-EP is handling all the electrophysiology constant for main JACC. And we've expanded our board. We now have Dr. Stevenson, Marshalinsky, and Alan Bogan who have joined our board. So it's one JACC and one family. And I'm talking to Dr. Kotzner and Dr. Newsill that hopefully next year in Prague, we hope to have simultaneous publications appearing in the JACC family of journals as a part of this meeting. So I'll stop here on time, thank my colleagues for this rare honor, and happy to take questions, comments. Thank you so much, Peter.
Cheers. Chief, it was a very elegant overview. Actually, it's very trustable, okay? It's like sympathetic is life-saving, parasympathetic is like, give a rest and we can sleep and we can digest, So the sympathetic is like, for me, like some excitement, right? So you already published and proved that the bilateral sympathectomy is crucial. If you compare your previous study, like a long time ago, you proved just the people after transplant, heart transplant. You have some study long time ago, I remember, that you get evidence about the dying principle of these bodies. And actually you prove that there are not so many with some felt like arrhythmia. So they are dying by other principles than ventricular fibrillation.
Yes.
Despite we have some evidence about INGROW, even for fully best model, heart transplant is the best model of the generation, right? But can you stress this?
Sure.
And then I will ask you one more question.
Yeah, it's a great question. So what Dr. Newsill asked is, in 2006, we came across a very interesting finding. As you know, UCLA does a huge number of transplants. We do about 100 transplants a year, and we've, cumulatively, we've transplanted over 2,000 patients. So something was very obvious. So if you have coronary vasospasm or coronary occlusion in a transplanted heart, you almost never see ventricular fibrillation. And in fact, you don't even see atrial fibrillation. So if you see atrial fibrillation in a transplanted heart, almost always it means the heart is rejecting. So that was a bit of a clue for us, saying that the nervous system is very important for fibrillation. So that was an interesting finding. But then the second part of the question that what Dr. Newsill asked is, how do those patients die? So we think that, of course, there's transplant coronary artery disease, and now we've even seen patients, 20, 25 years, long-term survivors after transplant. There is actually transplant coronary artery disease, and some of them, end up having bradycardic deaths, and some of them have also had refractory heart failure, asystolic, and a handful of patients, of course, have received a second transplant too. So it's an interesting conundrum, and I'd also like to sort of highlight a very interesting finding to all of you, and that is, you may have seen that there is a lot of data that's coming out of ECG with AI. And one of the interesting findings is somehow the ECG, when you look at like 10 million ECGs, you're able to predict who's going to have a low EF. And we now think that electrical propagation of the heart may be related to, sort of what is called the polarization of NAV 1.5, which is the sodium channel that all of our hearts need for phase 0 of the action potential. So one of the latest discoveries, and this was published also in JACC EP recently, shows that it's much easier to develop atrial fibrillation than ventricular fibrillation. That's why if you have any kind of viral disease, any inflammation, post-op cardiac surgery, it's much easier to get AFib than VFib because what is called apoptic coupling is much more stronger in the atrium compared to the ventricles. So last year, the new investigator award for JACC EP was for apoptic coupling. And we now think that this may have a fundamental explanation as to how electrical impulses propagate in the heart. So this basic science also has a lot of interventional and futuristic applications because you're going to now see a resurgence of treatments not targeting ion channels, but actually targeting the whole tissue level, like volume control of myocytes. So that's a very exciting era of research that is coming up. And I have a feeling that 100 years after Einthoven's Nobel Prize, we're going to end up making new discoveries about the ECG itself. So be tuned to this. There's going to be a lot more information that is going to come up on this field. And transplant, by the way, is a very good model for us to understand how these things work. So you're in a research institute over here. We are sitting here in the Czech Academy of Medical Sciences, right? It's a very prestigious location in your country. Thank you for that question, Peter.
Okay, thank you.
We had here one session initially where you were supposed to talk on a Sunday, and we had one talk about ganglion stellate blockade. And my colleague reviewed some available literature, and to my surprise, when we started with this strategy, I found that there are very few papers actually on clinical use of this, because it was in the hands of anesthesiologists, and they made a big business out of this because they always say it's too complicated, very high risk procedure. Now we use it routinely. We run even randomized trial, like sham procedure versus real blockade in storm patients, not with the prospect that we can treat these patients, but just to open time window for ablation, for instance, until next day. So how this is, and we have some collaborative work with Duke University, and
with John
they use that more for. They use that more for like if everything failed, to predict that if you will have a sympathectomy effect. So how you use in your institution?
So that's a good question. So there are two ways of doing this. One is don't wait for too long. We are big fans of catheter ablation of VT. That's important. VT ablation is life-saving. Therefore, the reason we got into sympathectomy was to stabilize the patient so that you can get them ablated. Anytime, anyhow, if you can ablate a patient, you should ablate. So that is job one. But the other aspect of this is waiting until it's too late is such a waste. Because it turns out, if you sort of combine these techniques, like for instance, we actually think that if you have CPVT, sympathectomy is going to be superior to an ICD. In fact, shocks in CPVT causes sympathoexcitation.
Right. Yes.
So if you think of the global application, in fact, I believe there was a colleague from Uzbekistan who was like talking about patients they were having. Sympathectomy is extremely well established. People have now used it for 40 years. So if you have channelopathy, the success rate is 95+%. We've done bilateral for structural heart disease where the plane is already crashing. And even those patients, the fact they lived was very reassuring. In the second part of your question, Duke University set up their program after sort of mimicking what we did. Johns Hopkins has done that. And I have a feeling that if centers like what you have in Prague, you start focusing on it, we should start doing the procedures. I think once we do interventional procedures, we feel that neuromodulation, when it's combined with catheter ablation procedures where you modulate the atria or the ventricular myocardium, you can have a more comprehensive procedure.
Because I have the same view that if you have VTs, you should ablate as soon as possible. But sometimes the patient has to be transported. So I see this stellate ganglion blockade as a tool to enable transport patient for ablation, or make
Stabilize.
it postpone, stabilize the patient, like you don't need to come at 2 o'clock night,
Yeah.
but you can do it in the morning when there is a sunshine already.
And
So
then
it's
the rest
always
of the lab has
much
come
better.
to work.
Yeah.
Good.
And you're right, and also thoracic epidural is another way. If you cannot do sympathectomy, many people know how to do thoracic epidural. Thoracic epidural also works upstream. So both approaches are sort of temporary block. And eventually, if you can access the stellate, you can actually end up ablating it or neuromodulating it using...
There is one group in Moravia. They cooperate with the site in Ostrava where they have CyberKnife, and we did this SBRT for ventricular arrhythmias. But they also described in European Heart Journal strategy to ablate with radiotherapy this ganglion stellate for refractory angina.
Yes.
So, do you have any?
I think it's a
experience
very, very good option. And in fact, we have now done a preliminary study of how to image the stellate. So the stellate is actually very hard to image by MRI for some reason. So I think the MRI sequences we use are not so suitable. But with a CT scan and ultrasound merge, you can very clearly localize it. And you can actually use those kinds of, radiation, external focused radiation to treat it, and that may be more scalable. Some of you may know that transcutaneous magnetic stimulation is being used by Dr. Marshalinski's group. It's external. You can just place the pad at the root of the neck, and you can use that to stabilize patients. That the technology is a little more specialized. It's not there in each center, but radiation therapy, of course, is also external focused, and I think this is going to be an important area. And I like it. Once we get control of it, Yosef, don't you think so? That more people will benefit by it. And I'm happy that angina, 100 years later, the treatment for angina, we've done 10 patients at UCLA for refractory angina. We've done sympathectomy, and it's been life-changing. 4 of those patients were referred for heart transplant because they were taking a bag full of medications. Their life was completely miserable. And we were able to do sympathectomy, and we took them off the transplant list because they got so much better, because it's microvascular constriction. So we should, and by the way, again, you saw the theme of the Prague meeting, right? Cardioneural ablation, you're looking at neuromodulation. So these therapies, with each passing year, more and more data is coming up. So it's going to be in the standard sort of repertoire of what we do. And hopefully, next year, ahead of time, if we're to do a simultaneous publication in JACC, we'll try to sort of, in the Prague Rhythm website, collect some important, so at least useful teaching material for, the anatomy for your symposium. Again, heartfelt congratulations to both of you. This is, over 25 years. It's a phenomenal contribution. I don't think anybody in the world does live cases better than Prague Rhythm, because the very first time I've been amazed. It's not easy. This is, just look at the setup behind. Hats off to you. Congratulations.
Thanks you for the kind words, and also for this kind offer to do some joint collaboration with JACC, because this would promote the meeting and also make it again qualitatively much better and higher level. So we certainly will discuss.
I come here officially on behalf of both journals to tell you, because we've now merged it, because it's very important. ACC has almost 60,000 members globally. And we'll probably do an email blast next year, so we should plan.
And we have this meeting is a hybrid, as you know. So today there are maybe 110 people online, but we can have online thousands.
Yeah, of course we can. And we'll promote it. We'll promote it through ACC next year.
That's a great offer.
It'll be a pleasure for us to do it. And again, for all the trainees in the audience, this is you people are the future. We really, really look forward to. You're learning about these things, which, the three of us, the chairs and myself, we had to discover this after becoming professors. But all of you right now in your training, you're getting exposed to it. So I think that'll change medicine.
Questions?
Questions?
Yeah, really nice talk and beautiful pictures of the sympathetic nerve system. If I understand your animal experiments correctly, you showed that by removing sympathetic drive through sympathectomy, you lowered the propensity of fibrillation with a subsequent later ischemic assault. And I just wanted to draw you out on your thoughts how that might apply to cardioneural ablation. So, you know, we're taking young people and removing their parasympathetic counterbalance. Do you think there is a chance that 40 years later we might be setting them up to fibrillate when they have their MI, or maybe develop atrial fibrillation in later life? And I guess the question in part relates to the impetus for cardioneural ablation, in that we're, you know, the angle, if you like, is to remove those later complications relating to pacemakers, which
Sure.
often manifest in that 30 to 40 year
Exactly.
time frame. Are we potentially trading one longer term issue for another?
It's a great question, and look here, and I'll give you this answer. So, if you take an extreme version of that view, and we've written a lot about this, we've worried about this, and in fact, from Leicester, Andre Eng in England has written about this. If you very extensively do cardioneural ablation, it's very, very, very bad for the heart. And in fact, we know that. The AFACT study published in JACC, where they surgically did extensive ablation of the fat pads, there was a higher risk of complication and it had no impact on AFib. Therefore, the current cardioneural ablation, there's clearly a signal, and I think it's because they ablate focal areas, they're able to get control of it. So when you get a chance, you can read a cover story that we published in journal Circulation Research. And in many of the cardioneural symposia, we've actually given a little bit of a tutorial. So you can certainly treat the headache by chopping off your head. I know, are we doing that, right? So that's the question. So in other words, are you placing a time bomb for the future, which is your question? I think we're getting away because we're doing very focal ablations, and we're probably getting some of the en passant fibers, but we are not extensively ablating. That's why these patients need to be followed up carefully. And I think that's, in the future, my hope is we'll be able to modulate it instead of permanently ablating it, which is why Botox actually has a scientific rationale is stronger, but these structures are very hard to study. So I'm hoping that in the next 3 to 5 years, there'll be more scientific answers to the questions you're asking, and they are extremely logical ones. In the early days, I think many of us are old enough to remember this, right? When we did slow pathway modification for AV and RT, one of the concerns, remember, even fast pathway modification was done in the early 90s. So the question was, oh my God, are these people going to end up needing more pacemakers later? Fortunately, at least we know that the story for AV and RT has shown that that is not the case. We now have had 20, 30-year follow-up studies that have been done. So what we are advising all the centers that do cardioneural ablation is to follow patients very carefully and also select patients very carefully. We are big fans of this field, but we have done only about a handful of cases at UCLA for heart block, because I think we all struggle with case selection. So, and I think it's, that would be the, a story in evolution answer. So I hope I answered your question. Other questions, comments? I think I went slightly over the time, so thank you so much.
Chief, thank you very much again for
Thank you again. Pleasure.
coming.
Pleasure. Oh. Thank you.
Chief,
So, and
is it
No,
right?
don't
No,
worry.
it's Pepper.
so we are coming to the last talk of this symposium.
This should be the last talk, right?
Yeah, yours is the last. Well, originally it was, again, there was some small change. Probably in program you have a different title, but as you know, Vivek Reddy had already his talk on Sunday, and Peter Neugel.
I must apologize him because he's always leaving Tuesday morning, so It was a little bit like not possible.
And
to
Peter
make
will
it.
tell us about pentaspline catheter pulse field supported by electroanatomical
And
mapping.
I have some introduction slides, but before, you've seen a lot about PFA. You've seen here like two main technologies right now. It's like pentaspline and Affera, like Sphere 9 catheter. And just guess, after 3 years after the CE mark came, 2021, for pentaspline, Farapulse, Farawave catheter, how many procedures you would expect in these 3 years when FDA got recently in the US, how many procedures worldwide was done? Just guess. I will help you in thousands, not in hundreds, in 1,000. Peppo.
I don't know,
We know
last year
that
we had about
manifest trial was based on, the last one was based on 17,000.
But last year we discussed, I had some data about pentaspline use. It was like 12, 13,000 last year, but at the beginning of last year. So now I think must be much, much more, because even in Czech Republic last year, we did 4,100 procedures with pentaspline technology. In small country with 10 million people, we did 4,000 plus.
And actually it was one of the highest number in Europe. And I will tell you, after US joined pentaspline, it's now estimated up to 70,000 procedures were done worldwide with this catheter. And why I'm stressing that, okay? It's not just because of number, but actually we went back. This 25 years, or more than 25 years here, we are speaking a bit about mapping, how important is mapping, how important is having just precise idea where we are with our catheters. And now we came with different sorts of energy, but without any mapping. With 70,000 procedures done in a very short period of time. And you are all familiar with this pentaspline pictures on the fluoro. And so somebody says, okay, fine, I'm compromised by having no mapping. So what for we need to have a mapping? Do we need to have a mapping for the PVI only, PVI plus posterior wall, or mitral lines, or whatever? So for sure, you can visualize these catheters, like pentaspline catheter, in other source of imaging. For example, I'm showing the CARTO, for example. Now you can tag the positions on, this is Philips Navigate software. You can tag the positions on the fluoro. You can, for sure, use Peppa Kautzner's favorite ultrasound. Okay, something happened here. Okay, sorry. Guys, I have a trouble. I have a different screen here. It's frozen.
Yeah, videos do not work, so that's why it's frozen.
It's fine. Let's skip it. Okay, I don't need it. Okay, fine. Okay. So, as I mentioned, so Manifest showed excellent data in terms of complication level, outcomes, or whatever. So, still speaking about, we have no option to visualize. So now, right now, the company came with the fusion of two things. Pentaspline catheter in one way, and fusing with Rhythmia, which is already Boston Scientific imaging system, to be able to fuse this imaging and catheter and visualize the catheter in some electroanatomical map. So even to create the map like with Orion catheter in terms of original arrhythmia system. And not only that, so we need to get some maneuvers, right? So we need to visualize some maneuvers on the map. So we need to have idea which spline is which. Up to now, we couldn't target one individual electrodes. We couldn't target too much the positioning, rotation of the flower. For example, if you want to, change the basket and rotate the basket and flower. So you have an idea on the floor what you are doing. Even on ice was sometimes not visible too much. And moreover, on the arrhythmia surface, you can project potential field of the energy projection during your application. So there are some steps what we can expect from this catheter, this far-view or far-wave nav catheter fused with arrhythmia. And I will probably end up is too much. And that's why they open very small study, some centers, not too many patients, 30 patients, to be enrolled in just study to observe what is unique on the system, and if we can get better with pentaspline catheter fused with arrhythmia itself. So we have a recorded case here. We did this case on Friday. So 70 years old female with paroxysmal atrial fibrillation. Actually, she was done with pentaspline catheter a year ago, January 2023, but just PVI only. And she recurred with some kind of arrhythmias. It was not clear. It was like some slight aberration. So like atrial fibrillation, then AT. So it was not sometimes easy to decide is like atrial fibrillation or ATs, like for example indicated here. So with this I will skip the PowerPoint and I will go for the case. Okay, should be running nice. So in the beginning we used the RF power transeptal system. Actually, for the guys, we showed several times this year this powered puncture. It's interesting because Boston Scientific acquired a company named Bellis, and which is a Canadian company, and you can see this. The snell, the wire, is very nicely going through the septum. This is the catheter, the pentaspline, pentanav, or far-wave nav catheter, which is a little bit different. Look at that. When you get flower, for the users of the pentaspline originally, you need to get some massage originally. This is much softer. I have some issues because if I use this catheter on the posterior wall, it potentially you can get some troubles in the stability on the posterior wall, but doesn't matter. So we introduced the pentaspline catheters or far-wave or far-view catheter to the body. Actually, you can see on the right upper screen the arrhythmia screen. So original arrhythmia screen. I don't know if I need to name it like arrhythmia or some other name. So still arrhythmia, and this pentaspline catheter on that, or far-view catheter on that. And we are starting to acquire the anatomy, and you can appreciate all the features you use from the arrhythmia. So you can visualize voltages, you can visualize propagation, activation, and so it's building up the anatomy. We have CT because the patient was not done in that study. The patient was done out of the study as a compassion case. So just to add, and I hope that we are going to the map at the left side, so left veins. Now we change the shape of the catheter to acquire more outside the veins. Hopefully, shortly we'll start to show you in 15-fold faster fashion creating the anatomy. So we appreciate that even this penta spline original catheter or far view catheter can really replicate all this anatomy. And you can see that they're a little bit delayed between originally the changing the shape on the fluoro and changing the shape on the arrhythmia system. I think this is trivial issues of the new application, but you can see that several times we changed the shape of the catheter for flower to basket to mimic or to adapt the catheter accordingly to the anatomy. And hopefully we'll be finished soon with all the voltage mapping. And as I stressed that this lady was done by pentaspline catheter more than 1 year ago, so we hopefully see some effect of original pulse field ablation on the PVs because it was only PVI. So in the end, we get some arrhythmia. So it's interesting that we try to get idea what's going on because we have an idea before, according the EKGs were not too much representative, and we got some arrhythmia, we got some AT with highly variable cycle length. It was not clear, it was stable, it was not clear it's like reentry or not. And on the map, we started to get what we should do. So we tried to extend our original lesions because all veins seem to be isolated. So we did more application, and you can see that projection of the field, when you have positioned the catheter, the field is projection, and then you can get application. I cannot say anything about accuracy of the projection of the field and actual application. But what we decided to get the veins and then posterior wall. So we add the posterior wall, and then we started to map. So as I mentioned, arrhythmia can adapt you, like can give you, the voltage information, substrate information, and activation as well. So we tried to get activation map, but as I mentioned, that cyclone was not so representative. Now I speed up again, and the patient was still in some atrial tachycardia, and we were not so happy with mapping, so we couldn't say too much what's going on. Even entrainments were not so optimal in left atrium, so we decided go from left atrium to right atrium. So probably you will see in a second. Now we introduce the catheter from left to right, so the same catheter, and we will try to create, again, right atrium. So before the map, we get a nice position of the CTI. We decided with CTI to simplify. And look at that, what's happened on the Pruka screen. We still try to get entrainments. We said, okay, we can get some positioning, and by just pressure of the catheter, so not only by the pacing, but actually we terminate the tachycardia. So we decided, okay, let's start again. So let's induce again. In the same position, you can see the catheter was still on the CTI. We are using a flower post on the CTI. Some centers, maybe ECAM is using more basket position. Actually, there are the questions how to avoid the septal position because it's a volumetric field. So now we induce the atrial tachycardia again. Actually, because we were on the CTI, we apply nitrates and to avoid the spasm. And we are ready for first application. On the arrhythmia screen, you see the projection of the field on the field. We apply first application and we terminate it. Okay. So despite the wobbling of the cycle end, we thought that actually we got some entrainments, but it was not optimal too much, but better than on the left. So it was clearly something dependent on the right atrium. And so in, again, faster fashion, we just finished the map of the CTI and the ablation of that region and continue with the mapping of right atrium. Actually, we performed the map and when we pacing from CS, and I think that so on the right upper screen you see all these mapping principles in right atrium. It's like we got voltage map, but actually after voltage map, we were actually able to, during the pacing, to replicate the activation, hopefully. And actually, in the right atrium, we really replicate the basket and flower. So actually, the anatomy is very, very representative. And we were focused on the CTI, which is really now building up on the right screen, the right upper screen. The signs of the activation was really like early meets late, and actually in a minute, in a second, you probably will see when we finish all the isthmus part of the right atrium, you will see one moment of the activation, I hope. Maybe I forgot to, it's activation. Okay, so it was clearly blocked on that side, and actually I will end up here the case. Okay, so thank Peppo to be able to show, because it was not planned, because we did the first case. Actually, it was 5th case in the world with Farah view catheter done, and actually it's open for discussion if we really need it or which way it's helpful. So I think that all those two main technologies are going a little bit closer, and I think that we are waiting for more cases and more experiences. Thank you.
Thank you very much. Well, I had opportunity to do animal case, but my view is that the success of Farapulse in last 2 or 3 years is mainly because it is simplified. You don't need mapping, especially for PVI. So I think I would still continue without electroanatomical mapping. And if you need mapping for some complex cases, you have a system like Affera, which we showed yesterday. We showed nicely that there was some channel of conduction across the posterior wall, even after previous pulse field ablation. So that's my view of the problem. But
and then Affera 360 is for what? Because
well, Affera 360 could be
360
also
like
used maybe without a mapping system.
Actually-
So this is, in my opinion, the future because it can simplify procedure. It can make it cheaper because always when you have to put some patches, it increases cost, increases complexity. So yeah, there might be different opinions, but I believe that this is in next couple of years there will be very pragmatic approach, and there will be more technologies to do simple single shot sort of ablation.
And actually, after all these experiences with pentaspline or for a pulse catheter, we really believe that we are really exposing the PFA, I mean electroporation, as we saw the case from unappropriate sinus tachycardia when you apply some PFA and you have phrenic nerve.
By the way,
paralysis,
Dan called me, and 10 minutes after the case was
like-
closed, it came back, the phrenic nerve. So there is no permanent damage.
No, it's not
to the
permanent,
phrenic,
but
yeah.
it's like really. I will no. I can. My experience with Farah-point catheter, I did the same without any single paralysis on phrenic. Okay. So this is the question about what is what. Okay. So what is pulse field means pulse field, but it's still discussion. So back to this pentaspline catheter or Farah-view catheter. I think it's helpful. For example, in the case you started as a simple PV something happened. So the option to map is always flexible and always better than nothing.
I have a little bit different view.
I agree. No, I agree with you. Okay, I agree with you. You are still talking, and I agree with you. Okay, so to simplify the things is the best, but don't forget that we are EPs, and we need to know something
We
more
are EPs,
than
but
interventionals.
we have procedure which is called MACE procedure, and this procedure, similar like transplant patient, they don't have AFib because they have excluded posterior wall. If we can do it without mapping system, and we can do pragmatic approach, so nobody is mapping now circuit for AV and RT because we know how it works. So this is my prediction that, you know, AFib is a large number of patients, and to make procedure widespread, democratic, we need simple procedure, no mapping, do posterior wall in persistent, maybe PVI only in paroxysmal, and no need for mapping. If you need mapping,
Actually, it's good
you need
because,
better mapping
because we
tool.
are using more entrainments now than before.
Yeah, well, you can
We
use
went back,
entrainment even
went
without
back,
mapping
went
system.
back, went to basic,
I use
right?
entrainment from Farapulse without mapping system.
Okay.
So it's about electrophysiology, not about mapping
Okay.
system. But that might be different opinion. People who don't use intracardiac
Chief.
echo may like it because it gives them some anatomy. So I do not argue that there is no need for such development, but I personally believe that it will be simplified. So, Chief.
So I have a question for you. You probably have the largest experience in the world. Have you ever seen right coronary artery spasm with CTI application?
Every single
Have
time.
you,
Shiv,
I'll repeat
Shiv,
this so that people can
Shiv,
hear it.
We
again.
studied
Can
that.
you hear this?
Okay.
I don't think it's,
It's working. It's working.
it's on. Okay.
Yeah, it's working. So every single time you apply on CTI, not with basket, but we have experience with this flower pulse, okay? Every single time we have coronaries there shooting, every single time it's asymptomatic or subclinical spasm. Every single time
So do you
on
see ST
CTI.
segment changes with that?
No.
Okay.
I can
It's
tell
like-
you,
Because
I was-
even the RF, the
it's
danger is
like
there with the RF too.
It's a surprise, kind of surprise. So huge spasm and no clinical evidence.
we did about, I don't know, out of 1,200 procedures, maybe one third was CTI, but we use different approach. We use sort of basket, lateral, never had any problem with AV conduction. And out of this, we saw 2 spasms, which resulted in ST elevation, which resolved after administration of dinitrate. I saw one in Slovakia when I was there as a proctor. So I saw 3 spasms which resulted in ST elevation, which was asymptomatic, but two patients were in general anesthesia, so we cannot judge. But there was no VF,
and
but
Vivek-
I know.
Vivek-
And we have
published a follow-up.
we have scenario. We have scenario very easy. The nitrates is really protecting. So if you use like 2 mics, wait 1 minute, apply next 2-3 minutes, again the bolus. Okay, you will play with the blood pressure, but it's okay. Okay, you can manage. But actually, it's really.
How much do you
Easy.
think contact matters if you're using PFA in the CTI? Because that becomes it's a very complex structure. So
Yeah, but if you
We have always contact.
with this,
No, how much
when we
contact?
saw this,
Yeah, how
when we
much?
use this basket, we use this Farah drive, which is steerable sheath. So with steerable sheath, you really get good contact. So you see even deformation of the basket on the ice, and you have very good contact. And it's rare that you really have to do more than just one go in the 3 different levels of the isthmus. When we always apply 3 or 4 pulses in one area. And,
Chief, I was shocked because, for example, we were together in PFA summit in Berlin during ERA, and there are some discussions about what we should do with. So there was some presentation, I hope, or during discussion, they have average of 41 application on mitral isthmus. 41.
wow.
You have PVI, for PVI only. You have 32, 34.
I think they also for mitral isthmus, they quoted this 30 or
No,
40.
it was so different when you have no contact, when you have no imaging. Okay?
When 2 people
But-
do the same thing, it's never the same. That's
Okay.
what I know from my practice.
Okay.
So from your advice, since both of you have used a lot of this, if you're going to use a flower catheter for a CTI, would you think it's safer still, although with the anatomic mapping you can see the field of view, it's still better to do a more lateral line? Is that what you'd recommend?
Well, yeah.
It's probably safer to be away from the central.
Chief, I can clearly tell you, I'm very, very cautious about some kind of septal position or some
of
kind of
course.
septal something. When you hit it, it's always some like blocks, okay? So
Yeah.
I don't want to say
So
too
it's
much,
better to
but-
have a lateral line
It's a
irrespective
very,
of
We
very
never had
use.
block, even transient, never.
But in septal position, if you are close to AV, it's danger.
Yeah, it's good safety practices. Thank you.
Okay.
Okay, so
Peppo. Oh,
I think if there
this
is,
not the end.
if there is, if there is no other question,
I'm not presenting. No.
No, I'm not presenting anything. I would like to thank to all of you for coming. I would like to thank to all our sponsors for support of this meeting, which makes it possible with their help. I also want to thank particularly to Hanna Klimentova as a project leader from CCL company for logistics and companies which did this transmission, because I think it's really on professional level, and I am looking forward to seeing you next year again in spring. I don't know yet which date, but we will work on it, and very soon
Chief,
we will
there's no
show it.
dates.
We will show it on our website just to mark a date in your calendar. And so have a safe trip home, and see you next year, latest, or maybe in the meantime somewhere on international congresses or national congresses.
Thank you,
Thanks.
guys. Thank you. So, you-